This is a question that we ask ourselves every day. What do I do now? And the answer is get back to the fundamentals, don't panic. So I'll start with a clinical vignette. This is a patient that is now about 2 years out from her pouch. This is a 52-year-old female presented with ulcerative colitis when she was a junior in high school. She's now 30 years out. Her disease has been primarily left-sided ulcerative colitis, and at this point, she is not on any treatment. She had been screened every 2 years since about the age of 40, and then last year, a year before that, presented with some low-grade dysplasia with no lesion associated with this. And symptomatically developed some bleeding, and even though her disease had been quiescent, she self-medicated and then eventually presented with colonoscopy and a mass at 8 centimeters. And this came back positive for a rectal cancer. So what do you do now? Well, let's talk a little bit about first the epidemiology of ulcerative colitis and colorectal cancer, and then specifically rectal cancer. So overall, the epidemiology, as we all know, is that patients with ulcerative colitis are more likely, possibly in the range of 2 to 6-fold over the general population. It is high in both ulcerative colitis and Crohn's disease. Rectal cancer in particular is higher incidence in ulcerative colitis, less so in Crohn's. And in fact, left-sided colitis and pancolitis have a higher risk. Ulcerative proctitis really has similar risk to the general population, interestingly. As we know, the probabilities increase over time. This patient was 30 years out, so the risk being higher. And primary sclerosing cholangitis in particular comes with a significantly higher risk. These patients present younger, and they present usually in the time frame of about 15 to 20 years. So when we think about the evaluation, standard workup is really in order, and don't forget your fundamentals. So in addition to the histopathology and a thorough oncologic evaluation and being sure to stage the patient. The location is incredibly important, and at the end of it, the most important thing is to be thinking about the oncologic treatment and the overall status. So in kind of stepping it through it, again, start with your oncologic evaluation. Obviously, metastatic disease, needing to get systemic therapy early. If it's locally advanced, the consideration for radiation, and we'll talk a bit about that. The location, especially with ulcerative colitis, is going to limit your options. Especially if colitis is part of the picture, it may limit things in that you may not be able to do a 3-stage procedure in somebody that has very active disease. And also, if the patient's having active disease, they may be immunosuppressed. And again, if you are unable to get below that tumor, it may not be possible to do a 3-stage procedure. The same fundamentals that Dr. Larson spoke about around patient-specific factors in considering whether or not you can do a pouch are in line here. Again, if a patient has poor function up front, he showed the statistics around obesity and how that can make doing a successful pouch challenging. Those things need to be taken into account, as well as patient preferences. So again, tailoring it to the patient that's in front of you and their disease, as well as their active colitis. So it does take really this multi-prong approach in decision-making. So this came down to really a philosophical question. To be or not to be, or rather to pouch or not to pouch, is really the question, assuming that the disease does not involve the sphincters. So again, Dr. Larson talked a bit about many of these things. Many people say, an older person shouldn't get a pouch, but really most of the evidence does say that in general, age is mostly just a number, and a physiologically very active elderly person, they often do well. Again, thinking about technically difficult issues, these are the same, whether this is a patient with a rectal cancer or not. And again, a patient that has a poor sphincter, you may not want to create a pouch, and you may be thinking about doing a total proctocolectomy and not a restorative procedure. Radiation directly to the pouch generally is associated with poor function, and I'll talk a bit about that in a moment. So that's a significant consideration. So what about radiation before a pouch? So there's limited data, but in general, there is more dysfunction in the data that we do have. It seems to indicate that. So this is a study that looked at sort of immediate outcomes in patients that had colon or rectal cancer who underwent a pouch. Only 9 of them underwent preoperative radiation. And what they found was that these patients tend to have similar complication rates, so not higher complication rates, but in the longer term, or the more immediate term, they did have a higher incident of chronic pouchitis, and then overall, similar to patients that had radiation directly to their pouch, they do have an increased rate of pouch failure. What about in the long term? So this is the largest series of patients that have been followed long term, and these are patients that have both received radiation prior to having their pouch or after having their pouch. And you can see that at a long-term follow-up of about 7-8 years, that overall there is a higher rate of frequency, incontinence, and poorer function in the long term. It's important in doing the planning, if a patient does need to have radiation and they're getting neoadjuvant chemoradiotherapy, that you're talking to your colleagues, the radiation therapists, to be thinking about the sphincters. If there is a way to avoid the sphincters, it's quite important, especially in these patients. And then I think the final significant consideration as far as technical considerations with a pouch are whether or not to do a mucosectomy. Many would recommend it. It does provide less of a need to survey that anal transition zone, and would therefore have a decreased risk of having a dysplasia or metachronous lesion. The con, of course, is that these patients do have slightly worse function in the long term. And then the other is that technically it can be much more difficult to get reach. You do need several additional centimeters, about 2 or so, to get that pouch to reach all the way down and to sew to the anus, directly to the anus. And it's really important to have that experience in doing it and counsel the patients about their function, that it could be slightly worse. And this is something you will not know necessarily going into the operation. So counseling your patient that indeed it may end up that you can't get a pouch is really important. So this patient did end up getting neoadjuvant chemoradiotherapy. We did take care to avoid the sphincters, did a 2-stage IPAA with a mucosectomy, and 2 years out, she has good function. So in summary, really keep to the fundamentals, work together with your interdisciplinary team. Some options may not be open to you because of some limitations in being able to do a 2 versus a 3-stage, and you do need to tailor to that patient. Patients that do get radiation, even prior to getting their pouch, will likely have worse function, and do consider mucosectomy strongly. Thank you for your time, and go to break.